So next chapter we are going to see today is inflammation. So yesterday we have seen the first chapter, that is going to be your cell injury adaptations and inclusions bodies. So today we are going to discuss about the inflammation and repair. So when I'm going to talk about the inflammation and repair, there are a few important things you need to understand. So inflammation, when I'm going to tell something called as inflammation, it is nothing but there is a response from the vascular tissues to some injurious stimulus. Okay, that is called as inflammation. So whenever there is going to be any foreign body or any injurious stimulus, your body reacts. Who is going to react in your body? Your vascular tissues. So basically, the inflammation is characterized into two. Okay, inflammation can be divided into two. One is acute inflammation. Second is going to be your chronic inflammation. Acute inflammation occurs in minutes to hours, whereas chronic inflammation takes days to months. And in acute inflammation, you will have neutrophils, which is going to be increased, whereas in chronic, it is going to be mononuclear cells, or we call it as monocytes and macrophages. Monocytes and macrophages, okay, which is going to increase. Along with that, you will also have lymphocytes. Okay, and remember, there is some exceptions too. In acute inflammation, okay, there is an exclusion, that is acute typhoid fever, which will have neutropenia. Whereas in a chronic inflammation, like your chronic pseudomonas infection, they will have neutrophilia. And tissue injury will be mild to self-limited in case of acute, whereas in chronic, it will be severe and progressive in nature. Okay, now moving on to talk about the five cardinal signs of inflammation. So you would have seen a picture probably in your lecture, in your class, your faculty would have shown you a picture of a old Greek illustration where they will be like giving five signs of inflammation: rubor, calor, dolor, tumor, and functional loss. Rubor means redness. Tumor means swelling. Calor means heat. Dolor means pain. And functional loss means loss of function. So rubor means redness. Why there is a redness? A redness is going to be occurring because of the vasodilatation of the small blood vessels. Why tumor occurs? Because of the exudation of fluid. Why calor? Because of the increase in the blood flow, what happens is there will be a hyperemia. Heat will be generated due to vasodilatation. Dolor means pain. This is going to be due to the stretching of tissue due to edema and chemical mediator called as bradykinin. Functional losses, loss of function, which is actually added by Virchow. Okay, now coming back towards the acute inflammation, before moving into acute inflammation, I want to tell you that this session again is going to be like a MCQ based session. So we will be like discussing some MCQs basically here. Now, acute inflammation. There are three major components of acute inflammation. First, there is going to be a vasodilatation, followed by increase in the vascular permeability. Then what happens? The leukocytes, which is present in the circulation, is going to emigrate. Okay, they are going to they are going to have a emigration from microcirculation and they are going to get activated. Now, the first one, what are the vascular changes that is going to take place? First, there is going to be vasoconstriction. So vasoconstriction is going to be the first change which you can visualize in an acute inflammation. Then what happens? There is a vasodilatation. Then there is an increase in the permeability, vasopermeability of the blood vessels. So these are the vascular changes that is going to take place. So in the vascular permeability, first there is going to be an immediate transient response that is going to be short-lived. Here there is going to be a formation of endothelial gap, which is caused by the release of histamine, bradykinin, and that is going to mainly affect your venules. Then what happens is there is going to be a sustained response, immediate sustained response, which is going to be due to direct endothelial injury caused by burns and detachments. This occurs in venules, capillaries, as well as in arterioles. Then the third stage is delayed prolonged leakage. That means for 2 to 12 hours. This is going to be due to some mild endothelial damage, which is late appearing, like your sunburn. Then comes your leukocyte mediated endothelial injury, which is going to be due to the damage in WBC. causing activation of leukocytes or endothelial injury. And the last and final is going to be increased transcytosis, which is formation of vesiculovascular organelles. This is caused by the histamine and VEGF, and this also occurs in the venules. Remember that endothelial cell retraction is same as that of endothelial cell contraction. So, உங்களோட latest Robbins 10th edition gives us as endothelial cell retraction. Retraction is nothing but endothelial cell contraction. Okay, wow. Now coming towards the cellular changes. So first what happens, there is going to be a vascular changes. Followed by vascular changes, there is going to be a cellular changes. Cellular changes is nothing but the leukocyte is being recruited from the vessel into the inflamed site. Okay, this can be divided into three stages. First stage is inside the lumen. Second stage is from the lumen to the endothelium. Third is outside the lumen. So how this is going to take place, that is what we are going to see one by one. Okay, so there is going to be a formation of endothelial gap, as I already told you, that is going to be a vascular response. Because of this, what happens is there is going to be a loss of fluid and the vessel diameter is also going to increase. This leads to slow blood flow. There is going to be concentration of red cells in your small vessels, and there is going to be increase in the viscosity of blood. Because of all these things, what happens is, first thing is going to be your margination that is going to take place. See, the blood vessels, you're going to have leukocyte. அப்ப என்ன ஆகுதுன்னா, அந்த ஃபர்ஸ்ட் அந்த லியூகோசைட் மார்ஜினுக்கு வரணும். ஸோ ஒரு இடத்துல இன்ஃப்ளேம் ஒரு இடத்துல வந்து யூ கோயிங் டு ஹேவ் அ எண்டோதீலியல் இன்ஜுரி அப்படின்னா, from that cell has to travel to the margin. That is called as margination. Okay, so the movement of leukocyte, principally neutrophils, occurring towards the periphery of your blood vessel. This occurs due to the increased vascular permeability. So this leads to vasodilatation. Selectins, they are going to play an important role. Okay, so now what happens? It is going to come to the margin. Now, once they come to the margin, what happens? They have to roll. Okay, they have to attach to the endothelium and they need to roll down. Okay, so the transient adhesion of leukocyte occurs with the endothelial cell. This is done by something called as selectin. Okay, so அப்ப ஒரு ரெண்டு பேர் அட்டாச் ஆகணும்னா, okay, so relationshipல ரெண்டு பேர் அட்டாச் ஆகணும்னா, both should contribute some amount of interest towards each other. So here the endothelium consists of selectins, whereas the WBC consists of Cl Lewis X glyprotein. Okay, Cl Lewis X. Now the Cl Lewis X is present in the WBC. In your endothelium, you are going to have E-selectin and P-selectin. E-selectin, P-selectin, you need to remember CD markers. E-selectin is CD62E. P-selectin is CD62P. You have L-selectin, that is CD62L. So in the P-selectin, E-selectin, P-selectin is present in platelet and endothelium. E-selectin is present only in the endothelium. Whereas the L-selectin, that is present in the leukocytes, neutrophils, monocyte, T cells, அங்கதான் present ஆயிருக்கு. So இது வந்து என்ன ஆகுது? They are going to go and attach to the ligand that is present in the WBC. எண்டோதீலியம்ல செலக்டின்ஸ் இருக்கு, அது WBCல இருக்கக்கூடிய லைகாண்ட்ல போய் அட்டாச் ஆகணும். அந்த லைகாண்டுக்கு பேரு Cl Lewis X glycoprotein. ஓகேவா? Clear, right? Any doubt in this? Now what happens is, third step after this is going to roll down and come. Okay, they are next is going to be adhesion. What is adhesion? Firm attachment of leukocyte to the endothelial cells. Now roll ஆகுது. Selectin is going and attaching to the Cl Lewis X. They are going to get attached. Now this adhesion has to be maintained. Who is going to maintain the adhesion? Integrin. So earlier we saw selectin. Now we are going to see something called as integrin. Okay, va? Integrin is of two types. Beta 1 integrin is there. Beta 2 integrin is there. Beta 1 integrin attached to the V camp. Beta 2 integrin attached to the I camp. Okay, I camp, V camp. Clear? Okay, so this I camp is going to get attached with the LFA1 and MAC1. LFA1 and MAC1, whereas VCAM is going to go and attach to the VLA molecules, VLA4. Okay, so you have to understand beta 2 integrin, beta 1 integrin going and attaching to the ICAM and VCAM. Clear? Any doubt? Beta 1 integrin, VCAM. Beta 2 integrin, ICAM. Clear? So now what you need to understand, why do I need to remember the first three steps? Margination, rolling, adhesion. So whenever there is going to be any deficiency, any problem in the synthesis of these chains, you call it as a leukocyte adhesion deficiency. So there is going to be a defect in the adhering of the leukocyte with the endothelium. If there is going to be a autosomal recessive condition where there is a synthesis, where is a problem in the synthesis of beta 2 integrin, beta 2 integrin synthesis problem irukku. Appadina, that is going to be leukocyte adhesion deficiency 1. This is caused by the defect in the CD18 molecule required for the biosynthesis of beta 2 chain shared by LFA1 and MAC1 integrin. Characterized by the recurrent bacterial infections, delayed separation of umbilical cord stump. All these things are going to take place in LAD1. Now coming to LAD2, leukocyte adhesion deficiency 2. What is this LAD2? LAD2 is nothing but, okay, so LAD2 is nothing but autosomal recessive condition which is caused by the absence of Cl Lewis X. When the Cl Lewis X is absent, so this is nothing but a fucose containing ligand for P-selectin, E-selectin. Because of the deficiency of or a defect of fucosyl transferase enzyme, they are going to inhibit the binding of fucose moiety, and that is called as LAD2, leukocyte adhesion deficiency type 2. It is a congenital disorder of glycosylation of protein. Okay, and patients have a recurrent bacterial infection, Bombay blood group, and the patient will be having a mental retardation. Now, you all know that now there is going to be a margination, rolling adhesion, which is taking place inside the lumen. So what is a pavementing? Pavementing is nothing but endothelium appears to be lined by WBC due to margination. This is called as pavementing. Now, what is the endothelial cell expression of E-selectin? It is a hallmark of acute cytosine mediated inflammation. P-selectin is stored in endothelium, viable palate bodies, and platelets alpha granules. L-selectin helps in lymphocyte homing to high endothelial venules. Integrin are transmembrane receptors that are bridges for cell-to-cell or cell-to extracellular matrix interaction. VCAM, ICAM are present in the endothelium. GP2B3A is or an integrin on the surface of blood platelets, and fibronectin, vitronectin, collagen, laminin, இது எல்லாமே வந்து going to be involved in the inside the lumen. Now coming to the next one. Now we are going to move towards the next one, that is going to be across the lumen. Now what happens? Now the WBC leukocytes are going to come and adhere to the endothelium. Now this leukocyte which is adhered has to migrate through the endothelium, and that is called as transmigration or diapedesis. That is called as transmigration or diapedesis. This occurs mainly in the post-capillary venules. Okay, and the most important molecule is going to be PCAM1 or CD31. Can you tell me what is the previous CD marker which is present for selectin? Selectin or CD marker is CD62. Whereas diabetes la use pandra PCAM or marker is CD31. PCAM or marker is CD31. So after transversing the endothelium, leukocyte pierces the basement membrane, probably secreting collagenase, and they are going to enter the extravascular tissues. Okay, so by adhering to the PCAM1 present in the endothelium, the CD31 that is present in your WBC, they are going to join together, they are going to migrate out. So the platelet endothelial cell adhesion molecule, PCAM is platelet endothelial cell adhesion molecule, most important adhesion molecule that is going to help in crossing the lumen. Now coming to the outside the lumen. Now what happens? The leukocyte has come out of the endothelium. Okay, so they are going to migrate in the tissue towards the chemotactic stimulus that is called as chemotaxis. So the unidirectional movement of leukocyte towards the site of injury along the chemical gradient. They are going to bind to the G protein coupled receptors on the surface leukocyte, and they are going to cause actin polymerization, and all movements are going to take place. Chemotactic agent. What is the chemotactic agent? Either they can be exogenous in nature or endogenous in nature. Exogenous nature, na, the bacterial product like N-formyl methionine, terminal amino acid, and some lipid. Endogenous product, na, unga C5A, complement activated protein, and arachidonic acid metabolite, LTB4. You have your cytokine, interleukin T8, interleukin 8, and then you're going to have your, this is going to be interleukin, sorry, this is going to be interleukin, this is going to be LTB4. Okay, this LTB4, and you have chemokines. All these things are going to act as a chemotactic agent. Now, after chemotaxis, what happens? Now, the leukocyte main role என்னன்னா, எந்த ஃபாரின் பாடி, எந்த இன்சல்ட், என்ன ஸ்டிமுலஸ் இருக்கோ அந்த இரிட்டேட் பண்ண ஸ்டிமுலஸை அது ஃபேகோசைட்டோஸ் பண்ணணும். ஸோ அந்த ஃபேகோசைட்டோசிஸ் இஸ் கோயிங் டு பி இன்வால்விங் 3 steps. First, it need to recognize. The particle to be injected by leukocytes are recognized by receptors present on the leukocyte surface. There are 3 receptors. One, mannose receptors. இன்னொன்று scavenger receptors. Third is macrophage receptors. Mannose receptors, they are going to recognize microbes and they are not host cells. They are part of molecule found in microbial cell wall, and mammalian glycoprotein and glycolipid contain terminal sialic acid or N-acetyl galactosamine. Scavenger receptors, they are going to bind the microbe and oxidize LDL particle. Macrophage integrins, MAC integrin, they are going to bind with microbes for phagocytosis. So first recognize பண்ணிடுது. Either mannose receptors மூலமாவோ இல்ல scavenger receptors மூலமாவோ இல்ல macrophage integrin மூலமாவோ it is going to first recognize. Next, it is going to cause opsonization. What is opsonization? It is going to coat the bacteria so that they are easily phagocytosed by the leukocyte. The chemicals causing opsonization, they are called as opsonin. And opsonization increases the efficiency of phagocytosis. Remember, opsonin, they are going to increase the efficacy of phagocytosis, efficiency of phagocytosis. Phagocytosis can occur even without opsonization. That is a very important thing you need to understand. Okay, so opsonization is just going to increase the efficiency of phagocytosis, but phagocytosis can occur even without opsonization. Opsonin is going to include C3b, Fc fragment of IgG antibody, plasma lectin, mannose binding lectin, and fibrinogen C-reactive protein. So fibrinogen, C3b, C4b, C5b, C-reactive protein, IgG, all these things are going to increase the efficiency of phagocytosis. Now, the third is going to be engulfment. Here, this occurs after the particle is bound to phagocyte receptors. Leukocyte cytoplasm forms pseudopores and they lead to the formation of phagosomes. The plasma membrane pinches off to form vesicle. This fuses with the lysosomal granule, resulting in discharge of the granule's content into the phagolysosome. Okay, phagocytosis requires polymerization of actin filament. Pinocytosis requires internalization into clathrin-coated pit. Pinocytosis is not dependent on actin cytoskeleton, but phagocytosis requires actin cytoskeleton. This is the point you need to understand. Okay, so again, this is diapedesis and this is chemotaxis. Remember, CD62 is E-selectin, CD106 is going to be VCAM, CD54 is ICAM, CD31 is PECAM. Okay, a platelet endothelium. Okay, we read right, PECAM, platelet endothelium cell adhesion molecule. Now, all your bacteria, cytokines, complement, arachidonic acid metabolite, leukotriene B4, all these are going to lead to phagocytosis. Phagocytosis is going to have different receptors. Either there is going to be a mannose receptor, scavenger receptor, macrophage receptor, or opsonin receptor. Mannose receptor is going to mainly focus on microbes. Similarly, macrophage integrin is going to focus on microbes. Whereas scavengers, they are going to oxidize your LDL, and opsonine receptors, they are going to be coating on surface of the bacteria, and that is going to cause IgG and C3b opsonine mediated phagocytosis. Clear? Now, after phagocytosis, what happens? Now the foreign body is engulfed by a leukocytes. Now it has to kill. This killing of microbial organism is going to be either oxygen dependent or they are going to be oxygen independent. So they are going to be either oxygen dependent or they will be oxygen independent. ரெண்டே ரெண்டு டைப் தான். ஆக்சிஜன் டிபெண்டா இருக்கும் இல்ல ஆக்சிஜன் இண்டிபெண்டா இருக்கும். Okay, wow. So the oxygen dependent pathway is nothing but, now what happens is, okay, you have oxygen dependent pathway. What happens in the oxygen dependent pathway? Very easy. There is going to be oxygen that is going to be entering. In the presence of NADPH oxidase, phagocyte oxidase, it is going to get converted into O2 minus. O2 minus in the presence of superoxide dismutase gets converted into H2O2. This H2O2, okay, either they are going to be adding on with nitrogen oxide to form ONOO minus, or H2O2 can get converted into hydroxyl ion, OH minus, or in the presence of any allied, and you have your MPO, okay, myeloperoxidase enzyme, they are going to convert it into HOCl, OCl minus. This hypochlorite ion is going to be toxic in nature, that is going to cause destruction of the bacteria or anything that is going to be present inside. Clear? So remember, phagolysosome, it is going to be due to the LYST gene at chromosome 11. So autosomal recessive disorder is there called as Chidia-Higashi syndrome. Chidia-Higashi syndrome is going to be present in oculocutaneous albinism. They are going to present with thrombocytopenia, peripheral neuropathy, giant granules, and repeated persistent infection and silvery hair. So CL Lewis X is required for the synthesis of H antigen, fucosyl transferase. Mutation in the FERMT13 gene leads to inactivation of integrin, and LAD1-like features will be there. This is called as LAD3. Next question. What is this NET? Neutrophilic extracellular trap. An important previous year question that I want you all to understand. Okay, so what is this NET? NET1? NET is nothing but an extracellular fibrillar network that provide high concentration of antimicrobial substance at the site of infection. They are going to prevent the spread of microbes by trapping them in the fibrils. Beneficial suicide na solvo ida. Neutrophils nucleus undergoes apoptosis to make netosis. That is called as NET. They consist of viscous meshwork of nuclear chromatin, which includes histones and associated DNA. It is going to include histones and associated DNA. Arginine is the most important amino acid among the NET. Nuclear chromatin in the NET is a source of nuclear antigen in the systemic autoimmune diseases. What is frustrated phagocytosis? This is seen in phagocytes encounter materials that cannot be easily ingested. Inability of WBC to ingest these substances causes a strong activation of lysosomal enzyme, causing leukocyte-mediated tissue injury. Okay, ma? This is all about your NET and your frustrated phagocytes. Now, coming to the next question, all of the following statements are true regarding the phenomena in the neutrophil shown below. So, this is going to be, can you see here, they are going to get entrapped. This is called as NET. So, NET does not involve mitochondrial enzymes. Okay, NET is not going to involve any mitochondrial enzyme. Nuclear chromatin in the NET are the source of nuclear antigen in systemic autoimmune disease. Correct? In the process of neutrophils maintains their nucleus and initiate the process. No, they cannot maintain their nucleus. Extracellular fibrillar network that provide high concentration of antimicrobial substance, the site of infection, true. NET formation in the circulation is dependent on platelet activation. Of course, yes, it depends on the platelet activation. In a cellular event, acute inflammation are seen in all except complement involved chemotaxis, true. ICAM in the adhesion of leukocyte, true. PCAM activation of leukocyte, no. Okay, selectin margination, correct. Next, a 6-year-old repeated skin infection culture from same showed the growth of staphylococcal aureus. On detailed analysis, genetic testing, one of the enzyme marked on A is deficient. What is this A? So I told you, right? So oxygen, should be converted into O2 minus in the presence of NADPH oxidase or phagocyte oxidase. Phagocyte oxidase. So when this enzyme is deficient, that is going to prevent the oxygen dependent pathway to take place. Okay, ma? So remember, respiratory burst is otherwise called as oxygen burst. Respiratory burst results in the rapid release of reactive oxygen species. NADPH oxidase is otherwise called as phagocyte oxidase or phagocyte NADPH oxidase. Okay, so this is chiefly responsible for formation of hydrogen peroxide. Once hydrogen peroxide is formed, you have something called as peroxisomes, where catalase will be there. This degrades hydrogen peroxide into water and oxygen. Superoxide dismutase causes conversion of superoxide ion into hydrogen peroxide. Superoxide ion to hydrogen peroxide. Similarly, glutathione peroxidase converts the reduced glutathione to homodimer. So now all these things are oxygen dependent killing. All this, the entire process is going to be oxygen dependent killing. Now you need to understand oxygen independent killing. So oxygen independent killing is based on the lysosomal enzymes and other lysosomal proteins. Neutrophils and monocytes contains lysosomal granules that contribute in the microbial killing. Neutrophils mainly has two types of granules. One is called as azurophilic granules, other is called as specific granules. Azurophilic granules, they are secreted higher concentration, myeloperoxidase, acid hydrolase, non-specific collagenase, etc. You have secondary granules or specific granules, they are going to be like having a lower concentration. Tertiary granules, they develop during chemotaxis, contain gelatinase and acid hydrolases. Okay, other microbial granule contents are defensins, catholicidins, lysozyme, lactoferrin, major basic protein. இதுல catholicidin அப்படிங்கிறது recent Robinsல கொண்டு வந்த new addition. Antimicrobial proteins that are found in the neutrophils are called as cathelicidins. Vitamin D will be upregulating genetic expression of human cathelicidin antimicrobial protein. Okay, so this is all about the different things that are present in the granules. Now coming to the next question, all are true about microbial killing except O2, H2O2 by SOD in the Mycobacteria, true. H2O2 MPO allied system is most efficient free radical scavenger system of body. It's not a scavenger system. It is a bactericidal that is going to produce free radicals. Glutathione peroxidase and catalase are free radical scavenger system of the body. True. Glutathione peroxidase and catalase are going to be free radical scavenger. Fenton reaction involves conversion of 3 plus to 2 plus. True. Already we saw what is Fenton's reaction in that yesterday's class. Now, regarding the granuloma, now we are going to move towards the next one, granuloma. Before moving into the granuloma, okay, I would like to add upon few important points. Chida-Higashi syndrome pathonla. Chida-Higashi syndrome is a autosomal recessive disease defect due to the lysosomal transport protein LYST encoded in the gene CHS1 at 1q42. Defective fusion of phagosome and lysosome occurs in the phagocyte. So there is going to be neutropenia, giant granules, aberrant phagolysosome fusions. Okay, albinism madri adu presence irukum. Chronic granulomatous disease that is going to be X-linked autosomal recessive disease. So they are going to be inherited disease in the microbicidal activity. So here there is going to be a defect in the gene that is encoding the phagocyte oxidase enzyme, that is NADPH oxidase. So when this NADPH oxidase is going to be a problem, that leads to chronic granulomatous disease. X-linked recessive will be more than your autosomal recessive disease. So diagnosis, how will you diagnose this? So we are going to diagnose this by test called as nitro blue tetrazoleum test. We are going to diagnose this by using nitro blue tetrazoleum test. So this depends upon the direct reduction of NBT by superoxide free radical to form an insoluble formazine. Negative in chronic granulomatous disease and positive in normal individuals. This test tells whether or not the PHOX enzyme that is present, that is going to be present, not how much they are affected, whether it's going to just tell whether they are present or not. And you also have dihydrorhodamine test and cytochrome C reduction assays. Okay, then comes the third one, myeloperoxidase deficiency. Both catalase positive and catalase negative organisms survive within the phagocyte and cause infection. In your CGD, catalase negative organism can be killed. Okay, in a chronic granulomatous disease, catalase negative organism can be killed. Okay, and remember, next is acquired leukocyte deficiency. So bone marrow suppression, diabetes, chronic dialysis, leukemia, etc. All these things are going to be occurring in the acquired leukocyte deficiency. Now coming to the next one, termination of acute inflammatory response. So it is going to be anti-inflammatory mediators like lipoxins, TGF beta, interleukin 10. Okay, all these are going to be like a anti-inflammatory mediators. Now coming to the pro-inflammatory mediators, that is going to be your TGF beta. TGF beta is anti-inflammatory mediator. Interleukin 10 is anti-inflammatory mediator. Lipoxin is anti-inflammatory mediator. So they are going to prevent the inflammatory response. Now moving towards the next question. Before moving to the next question, you need to remember a very important table. I just want you all to write it down. I just want you all to write mediators of inflammation. So what are the mediators of inflammation? We are going to see that. So mediators of inflammation, we can divide that into cellular mediators and we can divide it into plasma mediators. Cellular mediators, again, whether it is going to be a preformed mediators or they are going to be de novo mediators. What is de novo? De novo means newly formed. Plasma mediators are there. So what are the preformed mediators? Remember, the preformed mediators will be including, okay, histamine, serotonin, gelatinases, acid hydrolases, etc. Whereas de novo, whenever there is going to be an insult coming, only then there is going to be a production of certain mediators like your nitric oxide, arachidonic acid, and you have your platelet activating factor, cytokines, etc. Then coming to the plasma, so you're going to have a complement system, you're going to have a kinin system and thrombin system. So plasma, we are going to have three systems. One is going to be your complement system. Number two is going to be your bradykinin or simply kinin system. Third one is going to be your thrombin system. Thrombin system. Okay, so let's see one by one. Preformed, I told you that you have number one, histamine. Okay, histamine is formed from the amino acid known as histidine. So they are basically coming from the mast cells, platelets, and basophils. And they are the one that is causing the vascular responses. Immediately after an inflammation, what happens? There is going to be a vasodilatation, increase in the vascular permeability. And along with that, there will also be bronchoconstriction. Okay, then coming to the serotonin. Second one is going to be your serotonin. Serotonin is richest source in platelets and its primary function is to act as a neurotransmitter in the gastrointestinal system. Then comes your gelatinase and hydrolase. All these gelatinase, hydrolase, they are going to have a tertiary granule and they are going to be having some action in the attraction and also increasing the number of neutrophils at that particular area. So gelatinase and hydrolase. And de novo, you're going to have your nitric oxide. You know, nitric oxide is derived from the L-arginine, levoarginine, and the main function of it is to act as a potent vasodilator, that is endothelium derived growth factor and relaxation factor, and they are going to reduce the platelet aggregation. Then comes the second one, that is going to be your arachidonic acid metabolite. Arachidonic acid metabolite. So arachidonic acid that is derived from the dietary sources or by conversion from the essential fatty acid, linolenic acid. So what happens is, I think you would have read this in your biochemistry, but again, I'll just repeat this. So you have cell membrane phospholipids. So you have cell membrane phospholipids. Okay, this cell membrane phospholipids, they are going to be converted to arachidonic acid. Arachidonic acid in the presence of arachidonic acid in the presence of phospholipases. Phospholipases. This arachidonic acid, they are going to be acted by two enzymes. One is going to be your cyclooxygenase, cyclooxygenase, and second one is going to be your lipooxygenase, lipooxygenase. This cyclooxygenase converts your arachidonic acid to prostaglandin. So they are going to convert into prostaglandin. This prostaglandin gets converted into prostaglandin H2. Prostaglandin H2. This prostaglandin H2 gets differentiated to form prostaglandin I2, okay, or we call it as prostacyclin. Then you have your prostaglandin D2, you have prostaglandin E2. Prostaglandin E2, you have your prostaglandin F2 alpha, F2 alpha. Then you have your thromboxane A2, TXA2. Okay, then you have your lipooxygenase. What happens is, in lipooxygenase, a very, very important thing that you need to remember is lipooxygenase is going to help in giving rise to leukotrienes. It's going to give rise to leukotrienes. Okay, leukotrienes. Okay, and 1 minute. Leukotrienes, and leukotrienes is going to give LTC4, then LTD4, then LTE4. All these three are going to be a increase bronchospasm. They are going to lead to bronchospasm, bronchospasm, and vascular permeability. Increases the vascular permeability. Okay. Similarly, your prostacyclin, they are going to cause vasodilatation, platelet aggregation, Then your prostaglandin D2 is going to increase the mucus production. They are going to be increasing the mucus production. And prostaglandin E2. Prostaglandin E2 is going to increase the vasodilatation and vascular permeability. Again, it is going to cause vasodilatation and increases the permeability. Okay, and prostaglandin F2 alpha is going to be a one thing that is going to cause vasoconstriction, and they are going to be acting as a chemoattractant, and thromboxane A2, again, it is going to cause vasoconstriction, and they are going to cause platelet aggregation, Now, after completing this, as you all aware that I already told you, the first one is going to be your nitric oxide, second one is arachidonic acid, third one is going to be your platelet activating factor. Platelet activating factor is, again, as the name suggests, it is produced by your platelet, basophils, neutrophils, macrophages, and endothelial cells. The function is platelet aggregation, vasoconstriction, and bronchoconstriction. At lower concentration, it induces vasodilatation and increased venular permeability. Then last and finally in the D now is going to be your favorite one, cytokines. So in COVID-19, you would have read this terminology, right? Cytokine storm. Okay. So the cytokine, it is produced by the activated lymphocyte, macrophages, dendritic cells, connective tissues. Everyone are going to produce. And they have an important role in the immune and inflammatory reactions. So what is the main role of it? It can act as an autocrine. It can act as a paracrine or endocrine. What is the meaning? Autocrine means acting on the same cell. Paracrine means in the close proximities, and endocrine means on the long distance. Okay, remember, they are going to have a different action on different cells. So one cytokine, they can act at different cells in a different way. Okay, and different cytokines can have same effect. Okay, so these are the very important properties. Number one is going to be, it is going to act as a pleiotropic in nature, number one. And number two, they can be reductant. What is reductant? Reductant means different cytokines can have same effect. And third one is going to be a cascade effect. What is cascade effect? Cytokines can stimulate the production of another cytokine. So it's going to be like a cascade. And the most important cytokine responsible for systemic effect of inflammation are interleukin-1 and tumor necrosis factor alpha. So, a very important cytokine, if you ask me, is interleukin-1 and tumor necrosis factor alpha. Okay. Intrinsically, so many people will be having a fever, isn't it? So, why does the fever comes? Anyone knows? Yes, the fever comes because of the interleukins only. You have interleukin 1 alpha, interleukin 1 delta, TNF alpha, TNF beta, interferon alpha, interleukin 6. All are going to be pyrogenic cytokines. They are the one that causes fever in a person. Remember that the one interleukin that is not going to be a pyrogenic is interleukin 18. I want you all to remember, interleukin 18 is not pyrogenic in nature. Interleukin 1, interleukin 2, interleukin 8, interleukin TNF alpha, you have your TNF beta, interleukin 6, everyone are going to be pyrogenic in nature. Interleukin 18 is alone non-pyrogenic. Okay. And remember, chemokines mediate their action by having a chemokine receptor. So you have something called a CXCR and CCR. CXCR, CCR5, all these are going to be chemokines responsible for action. They are the chemokine receptors. Remember, CXCR4, CCR5 they act as a core receptor for binding and entry of HIV into the CD4 cells. See, again, I am repeating. So, in the chemokine receptors are the one that actually helps your HIV to come and bind to the CD4 cells. Interleukin 6 made by macrophage and other cells are involved in the local and systemic reaction. Interleukin 17 promotes neutrophil recruitment. Okay, remember this interleukin 1 and your TNF alpha, they are going to have variety of function. One is going to be endothelial activation. It is going to lead to endothelial activation. Second is activation of leukocytes. Activation of leukocytes. And third is the systemic acute reactions. Systemic acute reactions. So what are the systemic acute reactions like your fever, sepsis, cachexia, everything? So whatever we saw till now is cytokines. Now the next one which we are going to see is a chemokines. Okay. So இது வரைக்கும் நம்ம பார்த்தது cytokine. இப்போ நம்ம பார்க்க போறது chemokine. Okay. Chemokine is actually a family of cytokine. And they mainly act as a attractant. They are mainly acting as a chemoattractants of specific leukocytes. They are classified according to the arrangement of conserved cysteine residues in the mature proteins. So you have alpha chemokine, you have beta chemokine, gamma chemokine, CXC3. Okay, all there are different types of chemokine. Among them, I'll tell you some important points alone. Try to write down chemokines. Okay, chemokines, remember, alpha chemokines, they are called as CXC. What is a CXC? That means that two conserved cysteines are separated by one amino acid. X stands for amino acid. Okay, wow. This is alpha. Beta C-C. That means that there is two conserved cysteines, but they are not separated by any amino acid. And gamma chemokines is just one C. That means one conserved cysteine. And you have a last and final one that is going to be your CX3C. That means two conserved cysteines which are separated by three amino acids. So what is the importance of this? Alpha will be acting on neutrophils. Okay. And beta will be acting on all the cells, WBCs, except neutrophils. So they are going to act on all leukocytes except neutrophils. And gamma going to act on lymphocytes. And CX3C is going to act on monocytes and T cells. Okay, so examples is going to be interleukin 8, interleukin 1, TNF, all comes under alpha. And beta, example is going to be RANTES. RANTES, nothing but regulated and normal T cell expressed and secreted. And for gamma chemokine, you have your lymphotassin. And CX3C is fractalkine. Okay, fractalkine. Okay, so this comes to the end of about chemokine. So now we have completed some important points regarding the chemokine, and now moving on towards the plasma mediators. So now we have completed all the cellular mediators of inflammation. Now we are moving towards the plasma mediators of inflammation. In plasma mediators, remember you have three systems: complement, bradykinin, and you have your bradykinin, and we have the last one that is going to be your complement, bradykinin. What is the third one? Come on. Complement, Bradykinin, yes, thrombin or clotting mechanism. Okay, wow. So first one which we are going to see is a complement system. First one which we are going to see is a complement system. Okay, this system functions in both innate and adaptive immunity. The critical step that is present in your complement activation is proteolysis of component C3. So now I am going to explain you this very important thing that is going to be your complement system. See, complement system basically consists of three important things. One is a complex pathway, or we can call it as classical pathway. Classical pathway. Second is going to be your lectin pathway. Third is going to be alternate pathway. Okay, alternate pathway. So first is a classical pathway. Second is a lectin pathway. Third is going to be your alternate pathway. Clear? So in classical pathway, what happens is classical pathway is triggered by the fixation of C1 to antibody. Now, what happens? So there is going to be antibody. See, in all these things, what happens? There is going to be a antibody like your IgM or IgG, okay, IgM or IgG. So when there is going to be fixation of C1 that has combined with antigen. So antigen plus antibody along with antigen, antibody, antigen plus antibody plus C1. Okay, C1 consists of QRS component, QRS component. So what happens is this is going to trigger. This is going to trigger what? This is going to trigger convert your C2, C4 into C4B, C2A. Okay, C2A, C4B. Okay, wow. So this is going to get converted into C4B, C2A or C2A, C4B. Okay, this C2A, C4B is nothing but they are called as C3 convertase. They are going to be called as C3 convertase. Clear? Very important. Now what happens? This C3 convertase is going to come and it is going to convert your C3 to C3B and it is going to let your C3A out. Okay, now this C3B, what happens is this C3B, now it is going to join with C2A, C4B. So in overall, I can write like this, right? C2A, 4B, 3B. Can I write like this? This C4B, 2A, 3B is nothing but your C5 convertase. So this is nothing but your C5 convertase. What happens is this C5 convertase is going to convert your C5 into C5B. Now the C5A again comes out. C5A again is going to come out. So here you're going to have your C3A coming out. Here you're going to have C5A that is going to come out. So now you have your C5B. Now what happens is this C5B, they are going to join with C6. It is going to join with C7, C8, C9 to form C5B 6789. So this C5B6789, this is nothing but this is called as membrane attack complex or the one that leads to cell lysis. The one that leads to cell lysis. Okay, so this is how the classical pathway is going to work out. Okay, so now what is this or lectin pathway? Lectin pathway means nothing but the plasma mannose binding lectin. They are going to bind to the carbohydrate that is present on your microbe. So there is some carbohydrate that is present on microbe. So what happens is this mannose binding lectin binds with the carbohydrate that is present in the microbial agent. Okay, so that is going to, what it does is, it is going to convert your C2, C4. So this is also going to convert your C2, C4. It is going to convert your C2 and C4 to C2A, C4B. Okay, it is going to convert your C2A, C4B, that is C3 convertase. Okay, so that is going to be your lectin pathway. Now coming to the third one, alternate pathway. Alternate pathway, you have the microbial agent. Okay, the microbial agent consists of the complex polysaccharide. So there is some complex polysaccharide which is going to be present. Okay, so you have your complex polysaccharide which is going to be present. This complex polysaccharide which is going to be present, what happens is in the absence of antibody, they are going to form a complex. Okay, they are going to form a complex Okay, this is going to act as a C3 convertase. It is going to act as a C3 convertase. So, இது வந்து direct it is going to act as a C3 convertase and converts your C3 into C3b. It is going to directly convert your C3 into C3b. But the problem here is, okay, the problem here is, again, the C3 has to get amplified. How do the C3b, how do the C3 convertase gets amplified? Nothing but again the C3b is there, right? This C3b is going to come back as C3b BPB. So இதெல்லாம் வந்து நீங்க மனப்பாடம் பண்ற மாதிரி இருக்கும். இது வந்து again they are going to act as a C3 convertase. They are going to again act as a C3 convertase and again this cycle is going to get repeated. ஓகேவா? ஸோ இப்போ எனக்கு இது வந்து நான் மனப்பாடம் பண்ணிட்டேன் சார். பட் எதுக்காக நான் இதை படிக்கணும் அப்படின்னு நம்ம கேட்டோம்னா, வெரி சிம்பிள். All three pathways of complement activation, they are going to lead to the formation of active enzyme called as C3 convertase. This is going to split your C3 into C3A, C3B. And what is the importance of it? What is the importance of C3A? What is the importance of C3B? Remember? Okay, remember guys, C3A இருக்குல்ல, in the C3A, they are going to stimulate the release of histamine from the mast cell. So they are going to act as an anaphylotoxin. Anaphylotoxin. They are going to act as anaphylotoxin, both C3A and your C5A. So both C3A, C5A is going to act as an anaphylotoxin. Similarly, your C4A. Can you see here? C2 is going to divide into C2A, C2B. So you're going to have your C4 is divided into C4A, C4B. So இதிலிருந்து வெளில வரக்கூடிய C4B. You're going to have C4B coming out. That is going to also act as an anaphylotoxin. Similarly, you have the C4B. Okay, you have C4B, right? C4B is also going to act as a opsonization. Opsonization. Hope you remember in the first chapter where we discussed about this opsonization, right? So it is going to act as opsonization. And similarly, cell lysis. So what happens? The SMAC complex, they are going to lead to cell lysis. They are going to lead to death of the cell. Okay, now what happens is you need to control this complement system. Why do you need to control this complement system? In order to control the inflammation, you need to control the complement system. How do you control the complement system? Either we can actually inhibit this step. Okay, we can inhibit this step. How can we inhibit this step? By giving a drug that is going to block your C1. That is going to block your C1. Okay, or we can actually, what we can do is we can actually block the formation of C3 convertase. We can actually block the conversion of C3 convertase. Okay, we can actually block the conversion of C3 convertase enzyme by giving decay activating factor. Then you have CD59. CD59, what happens is it is going to inhibit the membrane attack complex. So your CD59 is going to inhibit the membrane attack complex. So your C3 convertase is going to be inhibited by the decay activating factor or CD59, and you have your C1q which is blocked by the C1 inhibitor. It can be blocked by the C1 inhibitor. Okay, so what are the diseases that are associated with complement system? Don't worry, again we will be reading the diseases in the immunology chapter. For now, remember this, that is more than enough. Now coming again, product of coagulation, don't worry, I will be discussing that in the hemodynamics in the next chapter. But for now, the next thing you have to remember is kinin. So now you are going to remember the next one, that is going to be your kinin. What is this kinin? See here, whenever you will be having something called as high molecular weight kinogens. Okay, kinins are a vasoactive peptides that are derived from the plasma protein called as kinogens. So you're going to have kininogens. This kininogens, what happens is by the action of kallikrein, by the action of kallikreins, by the action of kallikreins, what happens? Your kininogen converts into bradykinin. Bradykinin. Similarly, this how is this kallikreins are formed? How is this kallikreins are formed? See here, you are going to have something called as factor 12. This factor 12, in the presence of kinogen, it is going to get converted into factor 12A. This factor 12A, what happens? It converts your pre-kallikrein. Pre-kallikrein gets converted into kallikrein. This kallikrein, it is going to help in the production of bradykinin, as well as it is going to help in the production of plasmin from plasminogen. So your plasminogen gets converted into plasmin, and it is also going to help in activation of C5a protein. C5a helps in inflammatory responses. You all know that again. So remember, the function of bradykinin 2 is to increase the vascular permeability and vasodilatation, and they are going to cause smooth muscle contraction. They are going to cause smooth muscle contraction, and it is going to also lead to pain. It is going to cause pain. That is why I usually remember it like PDP. So PDP. So what is PDP? Pain, vasodilatation, increase in the permeability. Okay, so remember, so again, I'm just repeating about the acute inflammation. Remember, so acute inflammation can be of 4 types. So basically, whatever you read till now, any acute inflammation, they are of 4 types. There are 4 types. So what are the 4 different morphological patterns which you can see in the acute inflammation? Write it down. The first one is going to be catarrhal inflammation. Catarrhal inflammation. So it is a commonest type of inflammation. This causes increase in the mucus secretion, which you can see in the common cold. Second one is going to be serous inflammation. Second one is going to be serous inflammation. So what is serous inflammation? Exudation of cell poor fluid. Exudation of cell poor fluid. So like your effusions from the cavity. And third one is going to be fibrinous inflammation. Fibrinous inflammation. So there's a deposition of fibrin in the extracellular space due to the large vascular leak. And the fourth one is going to be purulent inflammation. Purulent inflammation, otherwise called as purulent inflammation, otherwise called as abscess, suppurative inflammation. Okay, wow. So what are the outcomes? So whenever there is going to be acute inflammation, what are the outcomes which will be present? So either the inflammation can be completely healing. So there is going to be a complete resolution. Okay, wow. Or there can be healing by formation of a scar by a connective tissue replacement. So scarring. So either can go to complete resolution, or it can lead to scarring, or it can progress to a chronic inflammation. It can progress to a chronic inflammation. It can progress to a chronic inflammation. Clear? Okay. Now coming to the chronic inflammation. So any hypersensitivity reaction, any persistent infection, prolonged exposure to any exogenous or endogenous toxic agents, all these things will be leading to a chronic inflammation. Chronic inflammation is characterized by infiltration of mononuclear cell macrophages and all these things. And very important hallmark which you have to remember in chronic inflammation, hallmark is going to be there will be a tissue destruction. There will be a tissue destruction. That is going to be a very important point. And they attempt to heal by angiogenesis and fibrosis. The main cell which is present in any chronic inflammation is going to be your macrophage. Macrophages are tissue cells that are derived from hematopoietic stem cells in the bone marrow, and they are developed in the fetal liver during the early development. And remember, the half-life of blood monocyte is just 1 day, whereas the lifespan of tissue macrophages is like several months to several years. Therefore, macrophages will be more in your body. The problem with macrophages is these macrophages are going to get activated. Once they get activated, these macrophages, they are going to be forming. They are going to be forming something called as granuloma. Okay, wow. So that's what we are going to see now. Okay, so macrophages is basically of 2 types. Macrophages basically is of 2 types. Okay, macrophages are basically of 2 types, macrophages. So they are going to be divided into classically activated macrophages, otherwise called as M1, and alternately activated macrophages or M2. M1 is actually induced by okay, interferon gamma. Interferon gamma. Whereas alternatively activated macrophages are induced by interleukin 4, interleukin 13, and they are going to release lysosomal enzymes. They are going to release lysosomal enzymes. and interleukin 1, interleukin 12, nitric oxide, etc. Whereas this alternatively activated macrophages, they will be releasing interleukin 10 and TGF beta, and they are involved in the host defense against microbes. They are involved in host defense against against microbes and microbes, and this is going to involve in anti-inflammatory actions. It is going to involve in the angiogenesis, tissue repair fibrosis. Okay, wow. So now coming towards the tissue macrophages. Before that, let's see. So regarding granuloma, which are the following is incorrect? Regarding granuloma, which are the following is incorrect? That is the question. So interferon gamma is most important cytokine. Warthin, Finkelday, giant cells are seen in the measles, and Derkes granuloma is seen in Plasmodium vivax infection. Stellate granuloma is seen in cat scratch disease. So let's, before moving into the granuloma, so I just want to add on one more important thing. Okay, so something called as tissue macrophages. So I want to add something called as tissue macrophages. What is this tissue macrophages? I'll just give you a time. You just answer me in the chat box. So what is the macrophage that is found in the liver is called as? Macrophage that is found in the liver is called as Kupffer cells. In spleen, we call it as littoral cells. CNS la microglia, synovium type A lining cells, bone la osteoclast, lung la alveolar macrophage, or we call it as dust cells, lymph nodes la sinus histiocytes, placenta la off Bowyer cells, kidney la mesangial cells. All these are tissue macrophage. What is the role of lymphocytes? Basically, dominant population and chronic inflammation is seen in the autoimmune and other hypersensitivity diseases. CD4 T cells, that CD4 plus T cells, they will be promoting inflammation via variety of cytokines. Activated B lymphocyte and antibody producing plasma cells are also present. Now coming to the morphological patterns, they are characterized by formation of granuloma. Remember, all your chronic inflammation, they are characterized by formation of granuloma. Okay, granuloma. What is a granuloma? Granuloma is nothing but it is a aggregation of activated macrophages. They are aggregation of activated macrophages that are surrounded by mononuclear cells, principally lymphocytes, and macrophage gets activated to form epithelioid cells or epithelium-like cells. Okay, wow. Some of the cells may fuse together. Remember, some of the cells may fuse together to form a bigger cell, and that bigger cell is what we call it as a giant cell. Remember, granuloma, either they can be of two types. Either they can be immune cells, or they can be a foreign body cells. Foreign body now, when it is going to be in the absence of T cell response. Absence of T cell response, like your talcum, suture, silica. Inge inflammatory response edume irukadu, and the refractile foreign body with polarized light can be seen. But what is the immune? That is going to be when there is going to be a persistent microbe or self-antigen. Again, it can be infective or it can be a non-infective. Infective, tuberculosis is there, cat scratch disease, syphilis, lymphogranuloma venereum, you have your brucellosis, leprosy, all these are infective conditions. And in a non-infective conditions, it can be sarcoidosis, inflammatory bowel disease, rheumatoid arthritis, vaginous granulomatosis, Hodgkin's lymphoma, etc. The point which you need to remember here is they will not ask you what is a granuloma, but what they will ask you is the mechanism of granuloma, number one. Number two, they will ask you what type of granuloma present in which type of cell, which type of disease. So for example, now if you take a TB, when the TB cells are going to come in, you have this complement system which is going to act, and you have your membrane attack complex that is going to come and engulf your TB. And that is going to release interferon gamma. This interferon gamma, what happens is they are going to further go and act on the CD4 cells and T helper cell 1. and that is going to cause a release of interferon gamma once again. And all these two, interferon gamma, you have your CD4, which is going to release interleukin 1, interleukin 12. All these are going to cause lymphocyte proliferation and differentiation. And second is going to be, there is going to be a formation of epithelium-like cells or epithelioid cells. Okay, so first what happens, there will be a foamy cytoplasm which will be elongated to form a slipper-shaped cells. And the most important cells here is going to be epithelioid cells more than your macrophage. Now you can see you're going to have a slipper-shaped or elongated cell is present, right? So these are the epithelioid cells. What happens? One epithelioid cells is going to get fused with other epithelioid cell because of the presence of surrounding lymphocyte. So all the lymphocytes, all your epithelioid cells, they are going to get fused together. They are going to get fused together to form a giant cell, multinucleated giant cell. Okay, well, so this multinucleated giant cell is going to consist of epithelioid cells. They are going to consist of collar of lymphocytes. They are going to consist of collar of lymphocytes, and all those interleukins are going to be together sticking to form a epithelioid cells sticking to form a giant cell. So remember, the main thing here is your T cells. So T cells, so mediator, it's going to be CD4 T helper cell 1. Okay, wow. So in TB, you call it as Langerhans giant cell. So because they are going to be like arranged peripherally like a horseshoe. ஓகேவா, இதே ஒரு ரேண்டம் அரேஞ்ச்மெண்ட் இருந்ததுன்னா ஃபாரின் பாடி டைப்பா இருக்கலாம். ஓகேவா, so now you are going to read different types. So see here, this is going to be a epithelioid cells. You are going to have a collar of lymphocytic infiltration, and then you are going to have your Langerhans cell. This is going to be a Langerhans cell. Can you see here? So horseshoe pattern la present ஆயிருந்தனா Langerhans giant cell. அதே இது பாருங்க, this is like a randomly arranged. So it's a foreign body type of giant cell. Now, where will you find the stellate granuloma? Remember, I'm now going to tell you different types of granuloma. So whenever you're going to have a picture like this, or whenever you're going to have given that there is going to be a stellate type of lesion, granuloma, then it is going to be a cat scratch disease. Here there is a foci of necrosis surrounded by granulomatous inflammation with giant cell. This is seen in cat scratch disease as well as lymphogranuloma venereum. Next is going to be a Dirk's granuloma. What is this Dirk's granuloma? When you're going to put a field stain, this is seen in cerebral malaria. Blood vessels will be there with a ring of falciparum malariae. Okay, Plasmodium falciparum species. Okay, then Warthin fickle giant cell, you're going to see in the measles. So eosinophilic viral inclusion body, both nuclear and cytoplasmic. They are atypical pneumonia, like your H pneumonia. Okay, so you will be seeing a fibrin ring. So remember, you will be seeing fibrin ring, or otherwise called as donut granuloma in the Q fever. Clear? Caseating granuloma seen in TB, non-caseating granuloma seen in the foreign body accumulation. Now, whenever I'm going to tell you giant cell can be physiological as well as pathological. Physiological, na you have osteoclast, syncytotrophoblast, megakaryocyte, இவங்க எல்லாருமே physiological giant cell. Pathological foreign body on the after sort arrange Langerhans giant cell in TB, Taunton giant cell. Remember, Taunton giant cell. What is this Taunton giant cell? Remember, Taunton giant cell now you will be having a surrounding like this, and in the center you will be having something like this. So surrounding will be pinkish in color. So in the இடம்லாம் pink இருக்கும், அங்கங்க ஒரு செல் இருக்கும், and நடுவுல மட்டும் you're going to have a cell. This is nothing but a ring of nuclei surrounded by a foamy cytoplasm. This is seen in the xanthomas. What is the type? Taunton's giant cell. Clear up? Then you're going to have your special type of giant cell. One is your Warthin Finkel-Day giant cell, and you also have your Reed-Sternberg cells, which is seen, and also your Aschoff giant cell, which is seen in rheumatoid arthritis. Okay, so in your rheumatoid heart disease. And remember, inclusion bodies. When you have your asteroid bodies can be present, or there can be a Schauman's body. Asteroid bodies, Schauman body, இது எல்லாமே வந்து நீங்க இன்னும் டீப்பா immunity chapterல படிப்பீங்க. Special types of granuloma, what you read is going to be your caseating granuloma, foreign body granuloma, palisaded granuloma. Remember, palisaded granuloma you will see in vaginous granulomatosis. stellate granuloma you see in the cat scratch disease, fibrin ring in the Q fever, and malarial granuloma, Dirk's granuloma, you'll be seeing Plasmodium falciparum. Illa doubt irukka? Remember, ulcerative colitis la you will not have granuloma. And you have something called as non-immune granuloma, like your silica granulomas. Necrotic granulomas are also present. Okay, all these things are very, very important. Okay, any doubt till now? Can we move towards the next question? Which type of histological image of ILR lymph node 30-year-old woman? So see here, so 30-year-old woman, you're going to have ILR lymph node abdina. In the picture pakumode, you're going to have a non-caseating granuloma. Whenever you have a non-caseating granuloma, your differential diagnosis must be going to sarcoidosis. Remember, okay, sarcoidosis will be presenting like this with a non-caseating granuloma and lymphocyte, and there is a ILR lymph node which is positive. So there, okay, let's see the options. Unilateral ILR lymphadenopathy is characteristic. No. In sarcoidosis, you will have a bilateral ILR lymphadenopathy. Serum ACE level is low in most of the patient. No, serum ACE level will be high in the sarcoidosis patient. Granuloma is of non-caseating type, true, and serum calcium level is decreased. Serum calcium level is increased. Let's move into this sarcoidosis in detail. So sarcoidosis is a non-caseating granuloma occurring in the multiple organs. Most common site is bilateral ILR lymph node, more than your lungs, liver, spleen, brain, nerves, எல்லா இடத்துலயுமே இருக்கும். ஸ்கின்ல இருந்தா அதுக்கு பேரு lupus perineo. Parotid and salivary glands miculis ன்னு சொல்லுவோம். Rarely it is also present in the kidney. Rarely it is also present in the kidney. And I told you, right, asteroid body, squamous body, all these things are going to be present in granuloma. So what happens is antigen, there will be an antigen. So this is going to be an unknown chronic antigen which is going to be present. So that is going to be taken by antigen presenting cells to T helper cell 1. T helper cell 1 will be producing interleukin 2, interleukin 12, interferon gamma, and TNF alpha. Interleukin 2 is again going to increase CD8 count as well as CD4 T cells. So if compare பண்ணீங்கன்னா CD8 T cells will be more in comparison to the CD4 cells will be more in comparison to the CD8 cells. And when you're going to do a microscopic examination, you're going to find asteroid body. What is this asteroid body? It's a stellate inclusion with numerous rays that is going to be radiating from the central core. Whereas what is a squamous body? So they are the large concentric calcification, often containing refractile calcium oxalate stone will be present inside. And when you're going to take a laboratory value, ACE levels will be raised, vitamin D3 level will be raised, calcium level will be raised. Okay, this is all about your sarcoidosis. So this is a caseating granuloma. So you can just directly tell that this is a TB case. So both necrotizing as well as non-necrotizing will be seen in the TB. Remember, always don't search regarding necrotizing granuloma alone. So sometimes even non-necrotizing granuloma will be seen. Okay, non-necrotizing granuloma is seen in the TB. Okay, aim of granuloma is to kill the bacilli. Oruvela, if the patient is having a less immunity, so more immunity in the immediately it moves into a caseating granuloma. Oruvela, patient has less TB, less immunity, TB bacilli cannot be killed. But TB bacilli kill agama irukkoodiya granuloma is a non-caseating granuloma. So that's what I want you all to remember. And the hallmark of any chronic inflammation is tissue destruction and fibrosis. So in TB, you will be having a fibrocavity lesions. Now the difference between a necrotizing and non-necrotizing. Necrotizing granuloma, anything that can be killed is called as necrotizing granuloma. And what is a non-necrotizing? Anything which cannot be killed. So TB can be killed, or TB in immunocompromised cannot be killed. But other infectious agents will be necrotizing granuloma. Whereas your foreign body, occupational lung disease, sarcoidosis, Hodgkin's lymphoma, foreign, okay, IBD, all these are going to lead to non-necrotizing lesions. So Horseshoe is seen in Langerhans giant cell, Taunton giant cell is seen in xanthoma. This is a suture. Can you see here? The need, can you see this thread? So suture, which will be having a facade arrangement, is a foreign body giant cell. Donut-shaped granuloma. This is donut-shaped granuloma, which is seen in the Q fever. You can see this in the liver and bone marrow biopsy. Okay, so with this, we are completing the very, very important topic that is going to be your chronic infection. Any doubt in this chronic infection? Any doubts? Next is going to be another recent update, that is going to be your acute phase reactants. Okay, which of the following is a negative acute phase reaction? So you have something called as negative and positive acute phase reactant. So what is the acute phase reactant? Inflammation is often associated with a cytokine-induced systemic reaction that are collectively called as acute phase response. சில இது வந்து in a inflammation they will be raised, but there are certain things that will be decreasing. So you have to know which is going to act as a positive acute phase reactant and which is going to act as a negative acute phase reactant. You should know both the things. Okay, so let's see. Let's go back and discuss about this acute phase reactant and then come again. So whenever there is going to be any inflammation, there is going to be interleukin 6, interleukin 1, TNF alpha, which is going to be released. So this is going to go to the liver. And in the liver, it is going is going to increase the acute phase reactant, and some will be decreasing in the acute phase reaction. Okay, the materials or the components that are going to raise is going to be your CRP, fibrinogen, that is going to be ESR. Then you're going to have your hepatoglobulin, ferritin, ceruloplasmin, acute serum amyloid. Whereas your albumin, transferrin, antithrombin, transthyretin, retinol binding protein, all these 5 are going to decrease in acute inflammation. Okay, so then now can you tell me whether albumin increase or decrease? Albumin decreases. Transferrin decreases. Ferritin decreases. C-reactive protein alone will be increasing. So what is the answer here? So the answer is going to be, which of the following is a negative acute phase reactant? The answer is A, B, and C. Okay, now, okay, let's see who is going to answer this. Identify the correct statement. Interleukin 12 activates macrophages. Is it true or false? For that, you need to know what are the interleukins and what are they going to activate or what are they going to inhibit, isn't it? Okay, see, remember. So you have interleukin 4, interleukin 5, interleukin 13. So what happens basically is, okay, whenever there is going to be any foreign body that is going to come, whenever there is going to be any foreign body that is going to be coming, so they are going to be presented by antigen presenting cells. Very important concept. I want you all to just listen carefully. Antigen presenting cells. This antigen presenting cells, they are going to take it by the you have your membrane complex will be present, major histocompatibility complex. Along with that, it is going to be presenting to the T helper cell. Now the question is, which T helper cell is your antigen presenting cell going to take your antigen and present? Whether it is your T helper cell 1 or whether it's your T helper cell 2 or whether it is T helper cell 17. So your antigen presenting cells in a chronic antigen like your TB, it is going to stimulate your interferon gamma. Whenever interferon gamma comes into the action, it will present it to the T helper cell 1. T helper cell 1 will be increasing interleukin 2, interleukin 12 and interferon gamma. Interleukin 2, interleukin 12, interferon gamma. இதில் interleukin 2 என்ன பண்ணுனா, they are going to stimulate your CD8 T cell and they are going to stimulate again your T helper 1 cell for further increase in the cytokines. Your interleukin 12 and interferon gamma, they are going to increase the macrophage number. இது வந்து chronic antigens. Now, in the case of any allergen or any parasite, allergy nale namak enna thonano, eosinophils should be there. Type 1 hypersensitivity reaction. So, allergens, parasites idella vandaduna, your antigen presenting cells will be stimulating interleukin 4. Anga interferon gamma, inge interleukin 4. That is going to in turn stimulate your T helper cell 2. So, if antigen presenting cells is going to present to the T helper cell 2. T helper cell 2 is going to give again 3 important things. Interleukin 4, interleukin 5, interleukin 13. You know, interleukin 4 is again going to act on Th2 and also it acts on B cells to produce immunoglobulin E. So it is differentiating your B cells to IgE. And interleukin 5 will be increasing the eosinophil level. Interleukin 13 will be increasing your mucin level. Now, if it is going to be a bacteria or fungus, your antigen presenting cells will be presenting to the T helper 17. Why? Because of the presence of interleukin 1 and interleukin 6. They are going to in turn stimulate interleukin 17, 22, 23. They are going to increase the neutrophil and causes acute reaction. Now, coming back to this question. Interleukin 12 activates macrophages. Is it true? Yes. Interleukin 12 suppresses T cells. No, interleukin 2 is going to increase the CD8 T cells. So it is going to activate your T cells. It does not suppress your T cells. Interleukin 2 inhibits cytotoxic cells. Is it true? Interleukin 2 inhibits cytotoxic cells. No, they will be activating cytotoxic cells. And TH2 activates interferon gamma. No, TH2 activates CD8 T cells. TH2 activates okay, TH2 is not going to activate your interferon gamma. TH2 will be activating your interleukin 4, interleukin 5, and interleukin 13. Okay, va? So now another important thing is, see, whenever antigen presenting cells in the presence of major histocompatibility complex presents antigen to the T helper cells. So there are two signals that is going to be coming. One is the signal that comes from your T helper cells, or the signal comes from CD28. That means that antigen presenting cells, in order to connect with your T helper cells, your antigen presenting cells are something called a CD80 or 86, and your T helper cell consists of CD28. Both the CD80, 86 and CD28 also join together in order to have this reaction taking place. So that is the signal number 2. And signal number 3 is the release of cytokines. The release of cytokines like interferon gamma, interleukin 4, interleukin 1, 6, that is also very important. Okay, so now coming back to this question is clear, I guess, to everyone. Next, we are going to move towards next question. A 33-year-old man presents with a 5-week history of cough, pain, and swelling and low-grade fever. Serum levels of creatine kinase is elevated. So whenever you're going to have this creatine kinase elevated, your mind should connect with your biochemistry, where we read that CK is going to be present in myocardium, CK is present in skeletal muscle, CK is present in the muscles basically. So muscle biopsy you're going to take, and it reveals numerous eosinophil. So your muscle is going to have eosinophil, and peripheral blood smearly eosinophils இருக்கு. அப்ப நமக்கு என்ன யோசிக்கணும் நீ உடனே? So eosinophils. So whenever there is going to be any eosinophil, then there can be either a allergic reaction or parasitic reaction. Appa it is going to stimulate interleukin 4, interleukin 5, interleukin 13. So out of the three options, only interleukin 5 is going to be related to the eosinophil of the patient. So interleukin 17 is going to be acute on chronic inflammation. Interleukin 1 is going to again increases in the bacterial or by viral infections. Interleukin 12 increases in macrophages. So the answer here is interleukin 5. The answer here is interleukin 5. Clear? So this is going to be a neutrophil. So this is going to be your neutrophil. This is going to be your eosinophil. This is going to be your okay, protein colored, aloe colored arca. So this is going to be a perinuclear aloe will be present. So this is nothing but your plasma cells. So plasma cells should be secreted, need not post-transitional modification. So there is an increase in the Golgi apparatus, and this Golgi apparatus increase is denoted as a perinuclear aloe. Next comes your lymphocytes. Lymphocytes are the small round bodies, and this is going to be macrophages. So macrophages are present in the chronic inflammations. Okay, next you are going to have your chemokines. I think I already discussed this chemokines in detail. Going to see this macrophages only in the chronic infections. Okay, so this is your chemokines, which we have already discussed. This is going to be the mediators, which we already discussed. Complement activation. This is going to be again the complement system, which is given more easier way. Can take a screenshot of it, which we have already discussed. And these are going to be the diseases that is going to be coming in a complement deficiencies. Okay, just take a screenshot. This might be helpful for you. Okay. Now, which of the following is true about RNAi? So RNAi is nothing but it is interference RNA. So RNAi abdina, it is nothing but it is a interference RNA. So this one question asked in 2023 NEET PG exam. That is why I just added some point of it. Just note down some points. Maybe it will be helpful for you. Okay, so you're not going to read it anywhere separately. So just write it down, and it may be helpful for you. So this small interference RNA, they are introduced experimentally into a cell. Why? To inhibit them. So since it is going to be given for inhibiting a cell, you call it as knocked down. So genetic engineering is of three types: gene knocked in, gene knocked out, and gene knocked down. Knocked in, adding a gene component. Knocked out, not removing a gene component. Whereas knocked down, now you're adding a gene component in order to inhibit it. So that is called as gene silencing, and that you have three things: microRNA, you have your small interference RNA, and you have a long nucleotide, long non-coding RNA. You have long non-coding RNA that is going to be called as LNC RNA. Now, coming to the last part of the discussion, that is going to be a tissue repair. So, the last part of discussion as far as your wound healing is concerned. So, which of the following statement is true regarding the picture depicted here? So, the picture given here is actually keloid. Okay, so keloid பத்தி பேசுறதுக்கு முன்னாடி first generalized we will talk about the wound healing. So remember, the repairing or healing refers to the incomplete restoration of tissue architecture and function after an injury. So repair is often used for parenchymal and connective tissues. Healing is used for surface epithelium. So you have to know the terminology, where you use repair and where you use healing. So what happens is the proliferation of cells will be taking place that is going to replace the lost structure. So this results in complete restitution of lost or damaged tissue. Based on the intrinsic proliferative capacity, you divide the tissues into labile tissue, stable tissue, permanent tissue. Labile tissue are continuously dividing. They completely regenerate. Whereas stable tissue, now the cells are in the G0 stage of your cell cycle. They have minimal proliferative capacity but capable of dividing in response to some injury. Whereas the permanent tissue means they are terminally differentiated and they are non-proliferative. ஓகேவா அந்த மாதிரி செல்ஸ் தான் வந்து பாத்தீங்கன்னா they yield by scar formation. Connective tissue deposition occurs in the scar formation. By laying down the connective fibrous tissue, like it is going to be of fibrosis. What is fibrosis? Extensive deposition of collagen. This fibrosis develops in the tissue spaces occupied by the inflammatory exudate, leading to organization. Okay, leading to organization. Who is going to be responsible for this? The transforming growth factor beta is responsible for that. It is a cytokine. The central role of repair in TGF beta is activation of alternatively activated M2 macrophages. Okay, so what happens is I want you all to just write down this table column. It's a very, very important thing. How the scar formation taking. There is going to be a tissue injury. So whenever there is going to be any tissue injury, what happens? It leads to inflammation. It leads to inflammation. That inflammation will be causing angiogenesis. Angiogenesis. So this angiogenesis is going to be taking place by activating the pro-angiogenic factors. Angiogenic factors like your vascular endothelial growth factor alpha, then you have fibroblast growth factor 2, you have your angiopoietin, sorry, it's an angiopoietin 1 and 2. Whereas second thing is going to be stabilizing the vessels. How do you stabilize the vessels? By platelet derived growth factor. Then you have TGF beta, notch signaling mechanism. Notch signaling mechanism. All these things are going to help in the stabilization of vessels. Now, this is going to lead to formation of granulation tissues. Granulation tissue. Remember, granuloma is different. Granulation tissue is different. Granulation tissue is formed by proliferation of fibroblast and thin-walled delicate capillaries, inflammatory cells, mainly macrophages. And you're going to have all the connective tissue deposition, like your platelet-derived growth factor, you have your TGF beta, etc. That is going to cause remodeling of connective tissue. How that remodeling of connective tissue takes place? Remodeling takes place by zinc-dependent matrix metalloproteinases. So, matrix metalloproteinases. So, what are the matrix metalloproteinases? Do you remember I told you something called as gelatinase? So, this gelatinase will be degrading the amorphous collagen and fibronectin. Then there is going to be collagenase, which will be cleaving your fibrillar collagens. And you have stromyelinase, which is going to degrade variety of ECM constituents, including your proteoglycan, laminin, fibronectin, and amorphous collagens. Okay. Now, once all these things are going to be there, now the tissue starts to heal. So, if it is a cutaneous skin healing, So there are three phases: inflammation, granulation tissue formation, wound contraction. Wound healing can be occurring either by a first intention or by a second intention. First intention na நான் ஒரு கத்தி எடுக்கிறேன், கையில கிழிக்கிறேன். Okay, so that is going to be a clean wound. Okay, it's a surgical incision. It will be having a less intense inflammatory reaction and limited granulation tissue formation. Either you're going in a bike, you're falling down from the bike, you're going to have a abrasion, you're going to have lacerations, and there is extensive loss of cells. More intense inflammatory reaction will be taking place, and very important is wound contraction will be present. So on the day zero, immediately you fall. On the day zero, there is going to be a blood clot that is going to occur. And after the blood clot occurring, just close your eyes and just imagine you're going to go in a bike, you fall down from the bike, you're going to have abrasion, you're going to have a laceration, you're going to have a contusions, abrasions and everything. So now when the laceration சொல்றதுக்கு just abrasion மட்டும் போய் நான் வச்சுக்கோங்க. So ஒரு blood clot ஆகுது அந்த இடத்துல. அதுக்கப்புறம் என்ன ஆகுதுன்னா அந்த இடத்துல நிறைய neutrophils வந்து accumulate ஆகும். After the neutrophils getting accumulated, there will be a thin epithelial layer that is covering your wound on the day 2. On day 3, what happens? There is going to be macrophage coming into. This macrophage comes into place and there is going to be appearance of granulation tissue. This granulation tissue mainly type 3 collagen. But the thing is, this type 3 collagen will not bridge the incision. There will be just deposition. On day 5, what happens? There will be a abundant granulation tissue formation and fibrils will be formed. This collagen fibrils are the one that is bridging the area of incision. And neovascularization takes place and full epithelial thickness occurs. On day 14, at the end of 2 weeks, what happens? The collagens gets accumulated, fibroblast gets proliferated, there will be a disappearance of inflammation, there will be a blanching beginning. And at 1 month, what happens is there's a replacement of collagen type 3 with collagen type 1. Collagen type 3 is a young one. Collagen type 1 is a older one. Which is more stable? Collagen type 1 is more stable than collagen type 3. It has a greater tensile strength and dermal appendages will be completely lost. Now, wound strength. Remember, sutured wounds are having approximately 70% of strength of normal skin. When the suture is removed at 1 week, wound strength is just 10%. அதே ஒரு 3 months அப்புறம் ஓகே அது என்ன ஆகும்னா கொஞ்சம் கொஞ்சமா wound strength வந்து increase ஆகி 70 to 80% ஆயிடும். But remember, the strength never becomes 100%. Okay, so now whenever there is going to be any abnormality in this repairing pattern, if there is going to be inadequate formation of granulation tissue, it leads to wound dehiscence. When there is increased abdominal pressure, there is going to be rupture of wound. If there is excess of granulation tissue formation, there is going to be a flesh that is going to come out. If there is excess of collagen formation, it leads to keloid and hypertrophic scar. Contractions can occur, or there can be delay in the wound healing if there is a foreign body, ischemia, diabetes, malnutrition, infection, steroids, zinc deficiencies, etc. Now coming to the disorder of excessive collagen. When there is an excessive collagen occurring, that leads to two important things: keloid and hypertrophic scar. Keloid will be away from the wound surface, whereas hypertrophic scar will be present on the wound surface. Usually, hypertrophic scar regresses, but keloid does not regress. And keloid are genetically predisposed. They are darker in nature. They occur after 2 months. And more commonly, since I'm telling it as after 2 months, collagen 1 is involved more than collagen 3. Whereas in hypertrophic scar, it's going to be occurring less than 2 months. Therefore, collagen 3 is more involved than collagen 1. And keloid will be having an abnormal arrangement, whereas hypertrophic scar will be having a parallel to the skin arrangement. This I already told you, sutures are removed at the end of 1 month. What will be the wound strength when compared to that of the unwounded skin? So remember, with suture, it is going to be 70%. After removal, first week, it is going to be around 10%. Here, the question is at the end of 1 month, that means 4 weeks. First month, it is 30%. Okay. And at the third month, it is going to be 70 to 80%. Okay. So there is going to be a remodeling of collagen. At third month, what happens? From the first month to third month, the type 3 collagen remodels to type 1 collagen in the presence of enzyme collagenase with matrix metalloproteinase in the presence of zinc and copper. இந்த கிராஸ் லிங்கிங் ஃபர்ஸ்ட் இருக்கக்கூடிய அந்த கிராஸ் லிங்கிங் வந்து கொலாஜன் 1க்கு இட் ரிக்வயர்ஸ் ஹைட்ராக்சிலேஷன் ஆஃப் புரோலின் அண்ட் லைசன்ஸ் ஆஃப் விட்டமின் சி இஸ் ரிக்வயர்ட். ஸோ அப்போ என்னென்ன தேவை? கொலாஜினேஸ் என்சைம்க்கு ஜிங்க் அண்ட் காப்பர் தேவை. சிமிலர்லி மெட்டலோப்ரோட்டீனேசஸ் வந்து ஆக்ட் பண்றதுக்கு தேர் ஷுட் பி அ லைசின் அண்ட் புரோலின் ஸோ தட் த going to be a cross linking. For that vitamin C is needed. So that is why after a fracture they will be giving you vitamin C tablet also. Okay, so cell again 3 types: labile, stable, permanent. I already discussed the sequence. Okay, so the sequence is already discussed. I already discussed the difference between the primary and secondary intention. I have discussed the pro-angiogenic factors, stabilizing factors, and remodeling factors. With this, we are actually completing a very important topic that is going to be inflammation, second chapter. So tomorrow we will be discussing the third chapter that is going to be hemodynamics. So second chapter is over. So tomorrow we will discuss hemodynamics. That will be the third chapter. Hemodynamics and genetic system, genetic diseases, I'll be covering totally as a single chapter, single topic. Okay, I'll cover it in a single set. Okay, so thank you so much. So see you tomorrow.